Okay. What's going on, guys? Welcome to another episode of the R2 podcast. I'm sitting down here with Sean and Alex, and we have a really cool conversation for you guys. This one is going to be very relevant to the clubs that we help with at school. We're diving deep into the alphabet soup. A lot of people like to call it. Just diving into some of those three-letter acronyms that we mention all the time that no one really understands. And sometimes I feel like it could be a little bit of a hindrance to the club, because say, hey, we're working on DNS today, and people are like, I have no idea what DNS is. And they don't get quite as excited about it as maybe we do. Yeah, so we're going to talk about a few different things. We're going to start off with the neurocentric approach, something that Dr. Phil Snell and his colleague Justin Dean worked together during this COVID pandemic, as they're calling it. And then we'll get into some, in that we'll talk a little about neurodynamics according to Shacklock and dermal traction methods. We'll get into McKenzie, SFMA, FRC, DNS, whole kit and caboodle. So yeah, do you guys have anything to add before we get into it?
No,
happy to be here.
Yeah, I think this is, I always say, starting off club, this is kind of the most important talk that we do every trimester, because like you said, alphabet soup, a lot of what R2P is taking a lot of these techniques that a lot of people don't know about and just mashing them together and seeing how they fit. So part of the reason that this is so important is it gives you a really strong framework for what we've got coming forward.
Totally. Yeah, and like I mentioned last podcast, this is the sort of stuff that's going to make you a great doctor coming out of school. Once you get through all the boards stuff, this is the cool stuff. So I'll start us off. I'll just get right into neurocentric approach. This was kind of one of the I was fortunate enough to have taken the upper quarter neurocentric approach seminar back in March, and I will be attending the lower quarter in 2 weeks here in Portland. It's pretty, I won't say revolutionary, but to me, this is the first time that I've been able to take all these different, three-letter acronyms and fit them neatly in together. I've often been confused as to what thing to apply, thinking that maybe you do one or the other, but they're not really connected. It's just kind of, what does this patient present with? Are they going to meet that classic McKenzie derangement presentation, or does this seem to be more of a neurodynamics issue, or should I just start with DNS and see where that takes me? So this was really a really cool seminar to go to, because he really laid it out, and this isn't a technique per se, it's a system. It's, how does a patient come in, and how do you figure out where along the nervous system is the issue occurring? So without getting too into the weeds, basically the way that the neurocentric approach works is that you have the 5 levels of the nervous system, and you start up top and then you work your way down to cutaneous and then cellular level. So we start with the brain, which is the first one that you're going to look at. So this could be anything that's going on in the person's mind that might be causing them some pain, trauma, fear, something like that. And so that's going to come from your history. When you're talking to a patient, you're going to try and find out if there's something going on there that might be causing their complaint. And then you're going to move into the spinal cord, IVF nerve root area. And so the way you would look at that is you do some more spinal cord differentiation. That's looking a little bit more like maybe a neurodynamics type test. And then we move into peripheral nerves. So again, this is where we kind of plug in our neurodynamics. With the spinal cord as well, you can kind of get into McKenzie. Again, it kind of gets a little deeper than that. It's hard to sum these things up in 5 minutes, but and then you get into peripheral nerves, which is neurodynamics, and then you can go into the cutaneous nerves, which are going to be your dermal traction, or YAP as it was previously called, and we'll dive into what those are. And then you get into the cellular level, which could be inflammation, could be some sort of process that's happening at the cellular level that's actually causing the issue, rather than it being a mechanical issue with how the nerves move in the body. So it's a really cool system because it allows you to take a patient, and from history down to the physical exam, you can evaluate all the different areas of the nervous system and see, okay, is this person, presenting with, a tendonitis, and is it coming from more cutaneous nerve activity, or is this something that's actually happening in their heads that we weren't able to figure out beforehand? So it's a really cool system. Sean, if you want to dive into maybe the McKenzie part of that, because that's kind of higher up on the hierarchy.
Yeah, for sure. So kind of a little introduction before we get too deep in the weeds here, that everything we talk about today is going to sound highly systematized. It's going to sound like this is what, like, step by step we go through with every patient, and it has to look this way, that way, otherwise you're missing something. It's not, but again, the reason, like we specified in the first podcast of why we're here, is trying to give that framework. It's trying to talk to students and talk amongst ourselves and try to figure out like what looks good in every patient exam, patient evaluation, part of the diagnostics and the treatment. So just that, with that little disclaimer out there, let's start at we're going to talk about like kind of those middle three of the neurocentric approach. So spinal cord, peripheral nerves, as well as the cutaneous nerves. So let's start with McKenzie. So out of the McKenzie Institute, you have their MDT, or their mechanical diagnosis and treatment. What this is trying to, at least in this neurocentric approach, look at the central part of the nervous system, so the spine and the brain, but especially that spinal cord. So a lot of times what we find is that things tend to refer, and when they refer out from the spine. So the Expo study that gets brought up a lot with a lot of the seminars and stuff that we as students go to talks about how often either a hip or a shoulder complaint comes from either the low back or the neck, respectively. What that means is, sure, there might be some kind of hip or shoulder complaint or issue. That doesn't mean that there's actually pathology or destruction or something going on in that joint. What it could be is that the spine itself is actually hypersensitized. Basically, it's a little angry, and with that, it's talking to and sending out pain signals to adjacent regions. So what McKenzie's goal is using a bunch of repetitively loaded motions that we can essentially tease out the spinal cord involvement of that condition. So what theirs is, it's basically an assessment and management tool, but most of the time it's patient-powered end range loading techniques. So we think of adjustments as definitely being like those end range games, that essentially you're trying to take a joint to its physiologic barrier and then going through that, essentially to desensitize the region, afferent impulse to the brain, calming things down. But also what we're trying to do here is give the patient that ability to kind of, in a way, in my mind, is like sending an adjustment home with them. I don't know if the other guys agree, but that's essentially how we look at it, is gives them the opportunity to treat themselves when we can't be with them 24 hours a day. So typically what McKenzie is looking for is what they call this phenomenon of a centralization pattern. Isn't always the case, but sometimes you'll have patients come in, pain's going down their leg. It could be going down into their hip, into the back of the knee, and all the way down to the foot. But with this repetitive motion, which could be a press up, which looks like a cobra stretch in yoga, it can be a child's pose, repeated flexions, essentially consistently hitting this end range in one of these directions will tend to centralize the symptoms. With the centralization, you're likely to also get some increased pain at the site of the back, whether that's the neck or the low back, dealing with upper and lower extremities respectively. But that's okay, because that means that we're essentially pulling the pain back out of the extremity and putting it into the spine, and that's somewhere we can treat it. So this can also be used in extremity joints, but the goal is usually to find that directional preference. Does the spine prefer flexion? Does it prefer extension? Same with the neck. But usually with all of these repetitive postures or movements, it's usually going to decrease, abolish, or centralize the symptoms. And that usually often improves a limitation in the movement that they had. So we talked about some of the movements, but usually this is something that you do in an initial evaluation, right? The reason why it's so high in this neurocentric approach is you want to make sure that you're doing your due diligence and ruling out the spine when necessary. If somebody comes in and you go, let's say 3, 4, 5 visits, and they're not getting any better, or maybe like 10%, but nothing major is changing, and you're like, maybe if I go back and like try some more of these extensions or more of these, what they call press ups, then maybe it would have like cleared the stuff out of their low back and out of their leg. And you find that that is true, and that does happen in that patient. Well, you just missed something that you could have found 4 treatments ago, right? So this is something that you definitely want to hit. Mackenzie usually says they want like 300 to 400, 500 reps. In our lives, in our clinics, we don't have time for that. We won't in the future as well. Typically, what I feel like most of us have found is like somewhere between 30 reps, maybe a couple of sets of those. Again, patient like loaded, they're doing it all on their own. If you see any change, that typically means you're going in the right direction. Send them home, do a bunch of those. But yeah, so that is Mackenzie's goal, is essentially, can you centralize or abolish pain either locally at the spine or peripherally in the extremities? Because the main thing you want to do is rule out that the spine has any involvement. Because if it does, that's not something you want to miss. Any other?
Yeah, you could, like you said, you could just be spending your entire time working on the knee when all the pain is coming from the spine, right? And then you could apply that same logic to if someone has trauma and you just keep working on their different area of their body, like say the pain is, in their leg, and you're working on the leg, but you haven't addressed the trauma, and then you're just wasting both your time. The other thing I want to just mention for people listening is just keeping in mind the fact that all 3 of these things that we're going to be talking about with Mackenzie, neurodynamics, and dermal traction all use movement in order to desensitize and treat the issue, which is kind of the cool thing about neurocentric approach, is this manual therapy way of just moving things around and how things will find a way to resolve. So it's a really cool phenomenon that you can link all those things together through a similar mechanism. So the next thing, when you come out of the spinal cord and the nerve root, we're going to get into peripheral nerves. So Sean, do you want to talk a little bit about neurodynamics and how it's used on peripheral nerves?
Yeah. So let's dig into part 2. So you go through, let's say 30, 60, 90 press ups or flexions or chin tucks or whatever it may be, and doesn't clear out. Symptoms are still there, maybe a slight benefit. So maybe you're kind of on sort of a path, but you're not there yet. What's next? So if we're sticking with the nerves, what's the next thing that comes out of the spinal cord is your nerve roots, your peripheral nerves. So you got nerves coming out of every level of your spine, but the ones that are especially important, especially for what we'll be treating, are the ones that come out of the brachial plexus in the neck and the lumbar plexus in the low back, because those are the ones that are going to be going out into the shoulder, the elbow, the wrist, and then down hip, knee, and foot and ankle. So those are the things that we want to make sure that if it's not a spinal cord involvement, or maybe that's just not the major factor at play here, then let's look at the nerves that are actually traveling out to the rest of the body. So Michael Shacklock is the PT that has done loads of research on neurodynamics. If you want to read that book, you will put yourself to sleep real fast. There's a lot of information there. But I think that book came out in like 2005. The idea is that the nerves themselves aren't static structures. These are not just tissue that stays still, which is good because we need them to move with our body. As we're walking, as we're, let's say, crawling or throwing a baseball, whatever it is, the nerve needs to be able to A, move around other structures in the area, and B, be able to move along with the limb that is kind of involved in that movement. Otherwise, if it was too tight or too loose, we might have some snapping, pulling, tugging, ripping, things that we don't want out of a nerve. Obviously, they need to be mobile themselves. Also, nerves are cells, like cell-based tissues, just like everything else. They crave blood flow. That's just the same way that most other tissues in the body are going to get their nutrients and kind of be continue to be useful structures in the body is they need blood flow. So providing movements to those structures can actually help desensitize them. So again, like Hunter said, a lot of what we're trying to do here is not just diagnose, but also treat and desensitize tissues. Because what you'll find a lot of the times is even like people tend to say, I have tight hamstrings. That doesn't mean that they're actually shortened muscle bellies or that the hamstrings are pulling at either their insertion or the origin on either side of the joint. What that typically means is you have nerve tension, right? A lot of times this nerve tension, or you like can't touch your toes because of this, can be cleared out with some press ups or cleared out with some things we'll talk about here, like flossing and tensioners. So Shacklock talks a lot about the key movements that come out of neurodynamics. You have flossing and you have tensioning. So the way we like to describe flossing is the idea of like flossing your teeth. Whenever, if you think of your nerve the same way as the floss in your teeth, it's the same motion. Whenever you're trying to pull a like thing of floss through your teeth, you're essentially clearing out any debris that's in the way, right? The same thing we tend to think happens with the nerve. There's fascia, there's muscles, there's all kinds of stuff that can kind of restrict the motion of nerves throughout the body. So there are some motions that are kind of repeated motions, just like Mackenzie, but more for the extremities, also kind of involving the spine itself, that tries to take that nerve and flosses it back and forth throughout the body. Again, the idea being trying to clear the way for this dynamic structure to move. So flossing is about is dynamicity a word? It sounds cool. How dynamic a structure is to move within the body, where tensioners, their job is to deal with elasticity, right? So this is how well the nerve can kind of stretch or pull from both ends, because nerves don't only need to move back and forth throughout the body. If you take your head and your arm and move them in opposite directions, you're actually pulling the nerve from both sides. And we want that to make sure, or we want to make sure that that's like able to be done without some kind of ripping or tearing motion that would happen in a nerve. So they also need to be elastic. So neurodynamics comes in, again, part of most initial exams as that like second or third part of that neurocentric hierarchy. But when we think that's not centrally involved, we start thinking maybe there's a peripheral involvement. So it might be the median nerve that's angry, or it might be the radial nerve or the sciatic nerve. And just by flossing or potentially tensioning that nerve, you're actually providing blood flow to the nerve to calm it down, which in turn might actually provide more range of motion, desensitize pain in the area, and better outcomes. So that's kind of where neurodynamics fits in. And if you don't think it's a central component or major factor in the condition, then you might have peripheral involvement. So I don't know, Alex, you got anything else to add to that?
Yeah, I think there's a few things that when you guys are looking at McKinsey and neurodynamics and using them to basically see if you'll change your audit, your painful or your functional audit, the thing being, you don't have to have back pain with either one of these for that to be the cause, or for it to be coming from a peripheral nerve, right? So radiating symptoms from the back all the way down to the leg could be, abolished with the McKinsey protocol, but it could also just be pain in your lower extremity. And that's where the two can kind of get confusing, right? Because you could just have calf pain and one could respond to a McKinsey press up and one could respond to seated sciatic nerve floss. So the cool thing with neurodynamics, you guys like literally learned the two most important orthos in school to rule these in or out. That being for the upper extremity, you've got upper limb tension test, and then which is part of Weiner's cluster, right? And then for the lower extremity, you have slumps, right? Which I don't know if that's how we've learned it at school. I don't know if other schools are the same, but I think it's a really good talking point and way to explain and show your patient that, hey, this is going to work. And it's not just a tight muscle, because when you take both ends of the nerve to full tension and you relax one end and their symptoms get better, you ask them, hey, does that take some of your symptom away? Yeah. Well, it can't be a muscle because you don't have a muscle that goes from, your back down to the bottom of your big toe. So that's how I'm sure, Sean, you've probably heard Brinker explain the same thing. It's, they get to see, oh, this took some of my pain away when I literally just pointed my foot forward in a slumps test. It can't be my hamstrings, right? So that's kind of all that I really was going to add to it. Sean did a really good job explaining it all. So
Yeah, I got nothing to add. That was great. So now let's go a little smaller than peripheral nerves. Alex, why don't you talk to us about DTM, formerly known as YAP, and when you would use that and what is it?
yeah, sure. So DTM, dermal traction method, as Connor mentioned, previously referred to as yapping or yank away pain. I think the guys just wanted to make it a little more scientific, so they threw on the DTM. But I feel like you don't see it as often, but it's definitely powerful, right? So as Connor mentioned, we're talking smaller than peripheral nerves. We're looking at the cutaneous innervation to the skin, right? And basically what can happen is those nerves can get compressed and, like Sean said, get irritated. They're not getting as much blood flow. They're not breathing as well. So then they get irritated. And all we have to do to calm them down or desensitize is decompress that area. So one of where the original name came out of it was that they would just grab skin over the sensitized area, pull it away from the body, and then just provide some movement into the area as they're decompressing the skin. Then, they realized some of the skin was hard to grab. So like around some of the bony areas, you could take those cups, you can just take manual therapy cups, suction using the vacuum, and then that'll hold the skin away while you're able to actually go through some more movements. And that can provide some relief. Something to mention with peripheral and cutaneous insults is that you want to make sure, as Sean said, rule out the spine, because those two presentations can be resolved with neurodynamics or dermal traction, but actually be a central issue. So again, rule the spine out. But as far as dermal traction goes, we're literally just pulling the skin away and then allowing those nerves some more room to breathe.
Perfect. Anything to add to that, Sean?
No, like Alex said, I think it's pretty rare that it does pop up. Well, I shouldn't say pretty rare that it pops up, but it's not as common as the other two. But when it's there and you like kind of pinch and roll the skin and it gets irritated, it's pretty clear that you've got some cutaneous innervation for sure. That's pretty angry.
Some of the more common areas that I've seen with it that I've been pretty interested in noticing are around the knee, like medial aspect of the knee. So coming off of saphenous, that'll give off branches, and I've seen that one. Personally had that, like where you cup that area, go through like a lateral lunge, and then pain's gone. Another would also be, you have a lot of cutaneous nerve innervation like around the low back as well, which I've seen docs use that like proprioceptively as well, to go through a cat-cow and get their brain to basically wake up that area.
Are you talking like cluneal nerve?
Yeah. So especially if you've got like any of those kind of entrapments, that would definitely be a time when you would cup.
Yeah, the big ones I've seen, cluneal nerve, dorsal scap. That's a big one. I was doing that on myself the other day, just with a cup and just kind of pulling on it and then just moving through the motion, and pretty crazy. Just it all went away. Same with the greater occipital nerve coming into the head. That's huge for headaches and stuff. So yeah, lots of gold in those ones. And then of course, coming out of the cutaneous nerves, and you get to the cellular level, and then you're looking at a whole other host of things you can do for that we're not going to get into. But that could be, if you go through the entire system and you're just not able to find any results, you might be looking at, something at the cellular level. So let's get into a little bit more kind of out of the neurology a bit, get more into the movement side of things. I find this really cool, this whole stability versus mobility. We're going to talk about SFMA and just the whole system of it, and breaking down where the dysfunction is in the body. And I'm going to throw it over to you, Sean, if you want to deep dive into this and explain to us what is SFMA, besides just a bunch of flowcharts and just more acronyms.
Yeah, more letters. We all need more letters. So SFMA comes with some what's the word I'm looking for? A little bit of kind of clarification. It's not the end all be all of functional assessment. I think it does a really good job of giving direction and framework, which again, as students, is a lot of what we need. But their big thing is trying to figure out what is a mobility issue, what's a stability issue, and what is something that is kind of a painful generator that we need to deal with before figuring out mobility versus stability. Now, mobility versus stability is a whole separate debate that you can get into of, are they actually separate? Can you still just treat them with one thing? We'll talk about DNS later, but a lot of times DNS is kind of in the realm of treats mobility while treating stability. But with SFMA, their goal is to give you a systematized way of breaking down joints and muscles in the body to figure out, do you need to provide a let's say an adjustment or some rehab or soft tissue or whatever to help the person deal with mobility or stability, right? So typically in the world that we're in, there's, like Connor talks about, there's a lot of flowcharts, easy to get lost in the weeds, easy to forget a lot of it, honestly. Top tier SFMA, which is a set of, I believe, 7 movements, is typically what most people that do SFMA are going to engage in, right? It's going to involve essentially touching your toes, multi-segmental flexion, trying to like lean back as far as you can, multi-segmental extension, rotation, deep squat, all those kinds of things to essentially get a gross motor pattern of how that person moves quickly. In school, we learn a lot about range of motion and to some extent gait, heel walk, toe walk, things like that. Maybe a little bit of overhead squat, like some functional movement patterns, but you don't really know where to put them or how to use them. SFMA's goal is to say, here's a quick 7 that you might see, they don't rotate very well. Then the question would be why? So with a lot of the other tools we have, we could try to figure out, is that a thoracic issue? Is that a pelvis issue? Is that a foot and ankle issue? Like where, at what point in the chain do they not rotate very well? SFMA's goal is, okay, well, let's see, is it the back or is it the hips? So they'll lock out one of them, basically puts you into a modified, like a child's pose, essentially modified child's pose, and have you rotate out of it. So at that point, essentially you're locking out the lumbar spine and rotating around just your thoracics. So the goal would be, do you hit this certain benchmark? If so, great, then it must not be your thoracic spine because we quote unquote locked everything else out. Then you could start looking elsewhere. So SFMA's goal would then be to say, it kind of puts you into categories for each of these 7 movements. And then the further you break them down, it checks, is that a functional, non-painful motion, which means that you're fine, you do it, you look great, move on. Is it functional? So it looks fine, but it's painful. That's something we should probably look at. Is it non-functional, but not painful? So you can't get there, but doesn't hurt. Or is it non-functional and painful? These are a bunch of categories to go down. And essentially, you just keep walking down their flow chart if you're going to deep dive it and try to figure out, do I need to provide this patient with more mobility or more stability? Again, this is where SFMA kind of has other systems that might use this a little bit or give you some mobility and stability options. But really, this is the RGB model where you might go into what we'll talk about next, which will be like FRC and DNS. Again, SFMA is not perfect. A lot of flow charts. Not everyone's going to deep dive into all these, but typically we'll use this as part of it, like an initial eval. And then if the patient is capable of generalized movement without debilitating pain, that's awesome. But then if there is pain, we'll try to desensitize that and come back later, like I said. But quick, easy audit gives you an idea of mobility, stability, motor control stuff. But also, if you get into the world of Liebenson, it's definitely going to provide a positive experience with movement, or that's the goal, is to show that, look, you might think that your low back hurts when you do anything, but look, you were able to bend down, touch your toes, you were able to lean back, look towards the ceiling, and that was fine. Like you were able to do that. So you're trying to reinstall patterns in the person's brain that they're able to do successfully without that negative experience of movement. Alex, what do you think about SFMA?
Yeah, I mean, you hit the nail on the head. I've used it a ton in student clinic, and since then, like how that's kind of where I start with checking off some of the boxes of things that can be used for audits. As you were mentioning, they classify the movements that you're getting from the exams of either functional or dysfunctional, and then painful or non-painful. And so those are literally the two audits we're looking for. What's the pain audit? What's the functional audit? And something that I learned, I didn't really realize till recently, but the thing that SFMA is really looking to change, the most important one, is the dysfunctional non-painful, because that truly is like, hey, I can't do something well, but I don't know that I can't because it doesn't hurt. So they're really not paying that much attention to it, but that really could be your key link that is bringing up the current chief complaint. So you do address the painful audit, but also make sure that you're addressing the function, because that's ultimately what's going to give them the most long-lasting effect from your trial of care. So yeah, SFMA is good for helping you establish that in your exam flow.
Yeah, it's especially when a patient comes in and you have no idea what's wrong or what to do. SFMA is going to give you something to do, and it's a way that it's a system that you can lean back on and have your client go through all these different movements. And by the end of it, it should point you in some direction that you can, or if not, then great. Like that patient probably doesn't need to be in here. But yeah, it's a great framework, and it's definitely a good place to start to figure out, where do I actually need to adjust here? Where do they actually, like, something's not working right along the kinetic chain and I don't know where. Run them through a SFMA screen and see what comes out of it. Do you want to touch on mobility before stability? Anything like that Greg Cook talks about? Just he's got and the joint by joint model, some of those things.
Yeah, I mean, I think you're not going to have a lot of times mobility without stability. I think the idea was that, and we'll talk about this at the FRC, I'm sure, here a little bit, that mobility itself maybe needs to come first, because you need to make sure that they can move in the areas that you're going to be stabilizing them in later. Mm-hmm. However, the question might be that maybe they don't have the stability to get into that area. And so good luck getting the mobility back, because they can't stabilize into that specific point. So I don't know. Like, I don't think there is a right answer. I think it's, again, we're trying to get away from it's vague, it depends. But I think general rule of thumb, you might need to find a point where they're lacking stability to maybe then gain them some more mobility. And I think that's where DNS comes in really well, is that you can do both at the same time. By stabilizing something and helping them use the correct musculature around a joint, you're actually going to improve the mobility at the same time.
Yeah, I was going to say that you can blend together Greg Cook's way of looking at it, and then Pavel Kolaj's way of looking at it, which is central stability for distal mobility, right? Which is, you can't fire a cannon off a canoe kind of thing. Like, if you don't have that stable base, then you're not going to be able to mobilize properly, because you don't have that central stability. So yeah, and let's just kind of bring it back, just to keep everything in context here, because it's a lot of stuff that we're throwing at people, a lot of different modalities that they probably never used, let alone heard of. So patient comes in, they present with pain. One of the first things you can do is run them through that neurocentric model, which is going to be, is their pain coming from their head? Is it coming from their spinal cord or central nervous system, the nerve roots? Is it peripheral? Is it in the cutaneous nerves, or is it at a cellular level? And then how would you guys from there fit SFMA into that model? Let's say you have unlimited time with a patient and you wanted to fit all these different modalities in. Where does that fit in for you guys?
Honestly, I feel like I'm doing that before I'm doing the other stuff, because the only one of those systems that's diagnostic and therapeutic would be your McKinsey. And so in which case would have already wanted to establish audits using SFMA and other things if you'd like to, but it's where I start. That way I can see if whatever we're doing is actually changing it, because otherwise you're you're just throwing techniques at it. You don't really know what's working and what's not.
Yeah, I should say that is part of the neurocentric approach, is what's that painful audit, and then that's being tested all the way through the system.
Gotcha.
What about you, Sean? How would you fit SFMA into?
Yeah, I think Alex is right. I think the cool thing about SFMA is it gives you an audit. I don't know 100%, and again, I'm starting seeing patients next week for the first time. That I don't know 100% that SFMA will give you, just from top tier, what is moving and what is not moving, and what's stable and what's not stable. But I think the goal that comes where SFMA fits into R2P's model is it might give you an audit. That's the hope. I think especially the deep squat. We were working with, like, at a half marathon, just working with some runners, and we'd quickly run them through a top tier. And there were a couple of people you'd find like, oh, my hamstrings are really tight when I go do a toe touch. Boom, audit. McKenzie press ups, do a bunch of them, come up, it's better. Cool, do more. Same thing, better. Or somebody going deep squat, yeah, it's my knee. Go through your neurocentric stuff, go through some maybe ART, soft tissue stuff. But SFMA is always gives you something dependable that you can go back to retest. So maybe I wasn't looking at their rotation stuff to be like, I don't know if they're quite hitting the mark I want them to. It's part of it, but it also tells me if that is either painful or restricted or whatever, and I can give them something, I can always go back to that as like a surefire audit.
Yeah, we should mention that SFMA is purely an assessment tool. It's not going to tell you what the treatment is. That's where all these other things come in. Whereas the things along the neurocentric model, they are in themselves treatments while assessments, right? Like if you're yanking on something and it feels better, that's your assessment that it's a cutaneous nerve, and it's also helping the pain, right? So where SFMA doesn't really do that, and that's where these next things are going to come into play with FRC and DNS. So I think that's a good transition. Let's go into FRC a little bit. Alex, what is FRC? How would you use it?
Yeah.
Talk to us about it.
So FRC, functional range conditioning, developed by Dr. Andrew Ospina, one of your fellow Canadians there, Connor.
Yes, sir.
Other side though, right?
Yeah, we're not close.
But he's Cairo out of Canada. For those of you, more acronyms to come, but for those of you who are familiar with his work, you've got basically two main categories of movements that he uses to, one, maintain range of motion, and two, increase range of motion. And so to maintain range of motion, he's going to use what we call CARs, or controlled articular rotations. That's basically taking a joint through its full range of motion, slow and controlled, actively, that is, and isolating all the other joints. So the other joints in the body are ideally staying still as you move through that range of motion through, let's say it's the glenohumeral joint. You're taking that through flexion, and then as you're going, you're externally rotating, extension, internal rotation, and then back around. So you're kind of drawing a big circle with the joint. He also mentioned some concepts of irradiation, where you're like taking the whole body and tensioning the other areas, and then not tensioning the area that's moving. But I don't really know how much validity there is to that, because you never really do that in real life. But regardless, you can take and choose what you want to out of it. But then you've got, for increasing range of motion, you have PAILs and rails, which longer acronym, but progressive angular isometric loading, and then regressive angular isometric loading. So all you're doing there is taking a joint to end range, what its current passive end range is, and then to progressively load it, you're going to, let's say an example will probably be easier for this. You're in a 90-90 position. Front leg is going to be that hip's externally rotated, back leg is internally rotated. So leaning over the front leg, you're trying to get to end range of external rotation on that hip. So to progressively load it, you're going to push the lateral side of your leg into the ground. Like you're using the musculature there to push into the ground. Then you're going to rails or regressively load it by using the musculature on the medial aspect of your leg, your adductors and such, to feel like you're pulling your leg up in towards your chest. You probably won't lift the leg off the ground, but the intention is that you're pulling your body closer into that end range. And then at the end, you relax. And so at the end of it, you should have an increased range of motion. We can obviously create some short lasting changes, which you guys, I mean, as a therapist, we can increase range of motion, get rid of pain very quickly. You know, in one visit, we should be able to do that. But I guess the premise behind the pails and rails in the cars is like, hey, how well am I affecting this whenever they leave my office and they go home? Am I maintaining the range of motion? Are we actually increasing it over time? Or is it just happening in the office? So that's kind of where all that gets to play a role in your treatment of things. And on the topic of mobility, to kind of very quickly circle back to whenever Sean was talking about mobility versus stability, and we didn't want to get into the it depends. One cool practical thing that I think you can use as a thing to think about when the patient's in front of you is something that I heard from Dr. Bo Beard when he's talking about kind of classifying phenotypes of patients. So if the patient in front of you is, let's say, a 14-year-old female diver, like she does platform diving, and she's fair-skinned, red hair. She probably has a 9 out of 9 on the Bates scale, very hypermobile. That kind of person is probably going to need more stability in their treatment, right? Because they have a lot of passive range of motion. Whereas someone, let's say you've got a power lifter, they're going to be inherently a little bit stiffer, which they need for their sport. Well, let's say it's not even a power lifter, but you've got like a jumper, right? So their tendons are very springy, needed for their sport, but they might need a little bit more increased range of motion for the pain that they have going on, which you can get into a whole conversation of like, are you making them worse at their sport by tackling function? But whole separate thing. But just something that I wanted to add as we're talking about mobility and stability, because that's kind of one thing that I've seen used to help, at least for me.
Yeah, I think that's really important because sometimes we just assume as chiropractors we need to adjust and bring mobility, and sometimes you just, and like you said, it could be like you have someone that big in there, like sometimes it's just obvious these people need to have more mobility, and you don't need all these special systems to determine that. You can just kind of figure it out just by looking at your patient. For those people who haven't tried pails and rails, they're extremely difficult, and I don't think I've ever done one where I haven't completely cramped up during my first set.
Oh yeah.
For students out there, do you guys go over like PIRs and RIs and stuff like that? It's essentially that on steroids, right? It's increasing range of motion, and when Andreo Spina talks about mobility, he's talking about active range of motion and like strength at that end range. So the idea behind it is if you can strengthen strengthen a motion at its end range, you're much less likely to be injured in that motion. And they show that, that strength curve, strength versus length curve, and just basically increasing at the edges of that curve your strength and being able to reduce the injuries that happen in that area. And I see guys on Instagram that do this stuff, like it's the only workouts they do is pails and rails, and they're just jacked. It's crazy. Even Andreo Spina, he's some of these guys are pretty crazy with it. But yeah, like you said, I think the protocol for a pail or rail is, is it a minute and a half or 2 minutes sitting in a passive stretch, and then you go like 15 seconds all out progressive, and then you go right into the regressive for 15 seconds or so. Yeah, it's tough, and it's pretty taxing on the nervous system too to get into those positions and really give it 100%. Anything to add, Sean?
No, not really. I think one thing to be clear about is mobility doesn't typically mean what the general population thinks it does. It doesn't mean you're more flexible. We kind of know with research right now that stretching isn't really giving the benefit that people think it does. A lot of it, probably what it is, goes back to the first part of what we've been talking about, which is that neurocentric theory of actually desensitizing nerves, which calm down muscles and give you more range of motion. So I think where FRCU does a really good job is the idea of active mobility. So it's controlling the range of motion that you do have. Because at the end of the day, if you have more range of motion than you can control, likely to lead to injury, likely to lead to what we might consider trigger points. This idea that if we are unable to control the range of motion that we do have, our body's going to find some system to kind of lock that down and make sure that we don't injure ourselves. So active mobility is pretty much almost always preferential, just because it gives us something to control.
I think I'm glad you mentioned that, Connor, because I forgot about that whole. It used to be in our slides, I think, the kind of the equation that Spina would use to explain like when an injury is going to happen, right? When your load exceeds that capacity, and that difference between active and passive range of motion in a joint, as Sean said, the bigger that difference, the higher your likelihood of, hey, I'm going to get myself into a position that I then can't control. And that's when I'm going to have an actual like tissue pathology happen, where I tear something or break something, right? So.
Totally. Yeah. Yeah. It's a fun one to work in. Last thing I think we're talking about is DNS. And I might say a little bit on it and then hand it off to you, Alex, just to talk a bit more about it. Because DNS, I just finished listening to a 2-hour podcast with Michael Rintala and Peter Attia about DNS, and they barely scratched the surface in 2 hours. And yeah, I was at his course last weekend for exercise 2, and it was just, anytime I go to something DNS, I'm blown away with just how intricate and well designed it is as a program. But essentially what DNS is it's dynamic neuromuscular stabilization. Comes out of the Prague School of Rehabilitation in Prague, Czech Republic. And I believe it's not even 20 years old as a system yet. It's still relatively new. But Pavel Kolaj out of the Czech Republic developed this system where he noticed through these developing infants these prerequisite motions that they would all adhere to. So when a baby learns the whole process of learning to move and walk, it happens pretty consistently with infants, the different motions they're able to achieve and the motor control that happens. So basically what he did was he developed these check marks, I guess, of these different movement patterns, and developed DNS, which I'll hand it off to you, Alex, to kind of explain more of the details of it. But it's really cool, and yeah.
As you mentioned, Connor, there can be many hours spent talking about DNS because there's just a lot of different facets to it. But as far as simplifying it for the sake of our podcast, you've got 2 basic tenets that make up like what DNS is all about. The things that Kolaj was noticing in how a baby stabilizes itself through those developmental milestones. You have first the concept of intra-abdominal pressure, which is going to, as Connor mentioned earlier, create central stability to then allow for distal mobility. If you envision a Coke can, right, full of Coke, if you were to try to squish it from the top and bottom, it's going to be easier to do that if there's no liquid in the can, right? But when there is fluid in the can, it's harder to actually squish that. So that's kind of what we're thinking about with our abdomen. The top and the bottom of the can are thoracic and pelvic diaphragms. And so when we inhale, you guys know the thoracic diaphragm descends. That's going to increase pressure within the abdomen. And how that provides stability is you are eccentrically loading the musculature around the abdomen, right? Your TVA, internal external obliques, rectus abdominis, but then it's even pushing posteriorly, right? Because it's going out 360 degrees onto the anterior aspect of the lumbar spine, which if we're looking at purely musculature, the lumbar spine is only being stabilized on the backside by erectors, multifidi, all of that musculature, which is going to be kind of, stabilizing it into extension. So by providing that hydraulic pressure against the front of it, we are decompressing the lumbar spine, but also then allowing the joints that come off the trunk to move more freely. So with all of the stages, once a baby start to actually develop that use of the diaphragm, because they can't do that initially, that's why they just kind of lay there. But once they start doing that, that carries out throughout all movements as they begin to walk or crawl, walk, all that, and then beyond in a childhood. But as we go to school and we sit at desks all day, we lose that ability. We don't move as much. We lose that ability to recruit that pressure. And it can be a game changer for somebody to teach them that ability to create the intra-abdominal pressure. So that in and of itself, one of the biggest things. Number two, joint centration. So when we create that pressure, we then allow proper muscle synergy around a joint, which then if you it's easier to conceptualize with your ball and socket joints. So glenohumeral and femoral acetabular, when you have that femur inside the acetabulum, basically centrated as properly as it can be, you've got the muscles with as efficient of a vector pulling on that joint as it could. So in that case, you're then going to be a little more stable, allowing for movement to be more efficient. And you're not going to be having that excess tension built up in any one particular muscle that we see with, when you start having trigger points in an area. Collage talks about how the trigger point's not in the muscle, it's in the brain. And that's exactly what we're getting after here with DNS. We're not changing the muscle per se. We're changing how the brain recognizes how that joint is being stabilized and where it's at in space, so that that trigger point will just release without having to, you can ischemic compression, dry needle, those will certainly abolish the trigger point, but we're actually trying to change the function so that the trigger points don't come back, right? Because a normally developing baby that hits those milestones, has that pressure and joints are centrated, they're not going to have trigger points. You're not going to feel that on a baby, but you're going to palpate all kinds of those on us. We just don't move as well. But I think Winchester talks about that, sideline position with the adductors. Like if he absolutely had to get rid of a trigger point and was going to be able to do it for like $1 million, that's the thing he goes after, is a sideline position from DNS, because it's that powerful at being able to change the function of a joint.
Okay, how does he do that?
How does he do the sideline?
Yeah.
So let's see. How can we describe it as without picture representation? Basically, have the patient sideline. They're going to be hip flexion 90 degrees, knee flexion 90 degrees, and we've got the complaint leg down, right? That's the leg we're going after. Cue the intra-abdominal pressure. He's standing in front of them on the table. Then you cue them to push that down leg, that knee into the table. So that's kind of their stable point, their fulcrum, right? And then from there, you can kind of start with an isometric load of, they're basically trying to, if you imagine the two legs being like a book, they're trying to close that book, close down the legs, approximate their legs, but he's not allowing them to move. So isometric, then a slow controlled eccentric motion where through this closed chain movement, you are pulling that top leg over to the down leg with some resistance. So he's not just letting them fully collapse, right? They're having to really control that. And then you regress. So you start to open the book, but you're resisting his hand as he applies pressure. So you're going back and forth there. And it might only take like 4 or 5 passes when before one, they're cooked, and two, like you've actually created some change. And at this point, they're not fixed, right? This is not like, oh, we got rid of it, you're good to go. But it's a great way to start than doing another intervention, right? It might be another DNS intervention. It might be, hey, we've opened up range of motion. So now we can actually get into a position that I wasn't going to be able to get you into before let's say it's like a lunge type position or something like that. So that's kind of how that would be implemented. I appreciate you keeping us on the specificity. And for the viewers out there, I hope, for the listeners, I hope that that was descriptive enough. If not, leave a comment and we'll be more descriptive next time.
See how many comments we have, if we can get to it.
Yeah.
See if we have time. Yeah, DNS, it's so cool because it's obviously a lifelong thing. It's not it's not prone press ups where you're going to go until your issue's gone. This is something, it's kind of more of a definition more so than like a treatment. Like this is just how we should be moving. And it's quite obvious when you have someone who's just very hypertonic in their upper traps and scalenes, and they just really can't seem to loosen up. And if you just spend some time with them, helping them breathe properly and breathe using their diaphragm and stop that chest expansion that they're used to, you can watch all those muscles start to loosen up and just finally let go, because they're no longer overusing these accessory breathing muscles. Again, I mean, I don't know how many times we're going to say this. DNS is such a vast world of treatment and assessment. We can't really cover it all today, nor are we qualified to cover it all. But it is probably I mean, if I was going to recommend 2 seminars, or a seminar for someone to take, obviously I got to plug neurocentric approach, because Phil Snell's been so gracious to us. But for getting people out of pain, Mackenzie is going to be such a big thing for people to take. It's not a very expensive course, and it's really going to get a lot of people feeling better, and it's going to clear up, because a lot of things do come from the spine. It's going to clear up a lot of issues that otherwise you'd be spending a lot of time working on, that are just going to be wasted on doing the wrong thing. And like Sean touched on, you're sending someone home with an adjustment. People love to hear like, oh, really? I don't need to come back to you every time that my back feels like it's thrown out and I get that pain in my leg. And they're going to refer people to you. They're going to love to hear that you actually don't want them coming back every single time. You know, you want them to feel that, you know, they're in charge of their own health, and, you know, a chiropractor doesn't have the magic fix every single time. But for me, DNS just helped me understand the human body more than any other thing has. It's like it like the 2 principles, like you said, the pillars are joint centration and intra-abdominal pressure, but you fully learn how the body is able to move and compensate. And by actually going to a course and feeling it on yourself and going through the motions, and you know, it's every time I think I'm in the right spot, and I'll call over the instructor. I was like, hey, can you give me some cues here? And I just get completely moved out from where I was. And they're like, no, you should be here. Your chest needs to be down. This should be up here. You gotta. And every single time I learn something new that I'm just like, this is crazy. Like, I can't believe I've made it this far through life with with these. Like, I don't even know how I move. It's just so dysfunctional. So, but yeah, in terms of how we apply it in our assessment and treatment, how would you guys throw this in? I mean, we've gone through neurocentric approach, which we should be clear that a lot of people will just that haven't. I mean, neurocentric approach is a pretty novel idea. A lot of doctors that I've talked to, they'll start right at Mackenzie / some neurodynamics, like a slump test or something like that, just to make sure that this is a Mackenzie issue rather than a peripheral nerve issue. So, I mean, that's kind of built into the neurocentric approach right there, but they'll start with something like that, and then they'll move into an SFMA. And then from there, they'll typically use DNS as the treatment. Obviously, Mackenzie prone press ups, depending on what they present with. What do you guys think about that? How would you throw DNS into the mix with all these things?
Yeah, I think DNS comes in very, very heavily and very strongly when you're starting to look into what most people would classify as rehab. One thing that kind of blew my mind when I took a DNS course was whenever you think of DNS and you think of giving it to your patients, the thought is that they need to be exhausted, burnt, cooked, all that stuff every time. It's not the case. Most of the time, you're actually making still significant change with low, low intensity. However, a lot of times when you see that shaking that they get, that typically means that their brain is currently in overdrive trying to figure out what the heck's going on. It gives their body a stimulus that they're not used to, and means that probably you have those little stabilizers at work that haven't been at work for a while, trying to figure out what you're trying to do to them. But I think the cool thing about DNS is, I always bring this up, so stop me if I've said before, but you can switch in the body the origins and insertions of muscles, which is not something that you really get taught in your traditional anatomy lab. A lot of times you think open chain, the bicep brings the hand closer to the shoulder, elbow flexion. You think the serratus takes your hand and drives like into flexion up and away, kind of that pressing bench press motion. What opened my eyes with DNS was that actually it depends what the stable structure is. So if you think of DNS 3-month prone, so for listeners, it's basically tummy time for a baby when their forearms are like under their head and they're kind of pressing themselves back into, I don't know how to describe it, but essentially your back is lifted up off the ground, your head's facing forward, kind of neutral spine. But the idea being that at that point, you've changed the stabilization factor, that it's now your arms. So instead of the serratus taking the scapula and pulling it around the thoracic wall, you're actually taking the rib cage and bringing it back into the scapula. So it switches the origin insertion and changes the direction of the muscle. So DNS does a really good job of not just being like kind of a big rehab arm of what we do here at R2P, but also lets you target muscles in ways that they're not used to being loaded, because we don't do a lot of that anymore. If you think most of what you do in your day-to-day life, a lot of it is pulling things towards you, right? A lot of times it's pulling the mouse towards you, pulling your phone towards you, pulling your water bottle towards you. We don't do a lot of pushing away. DNS kind of flips that a little bit and does a lot more of that motion that is away from your body and resist in that motion, in that direction, because it's kind of a lot of what infants do as well, is they have to change the way they interact with their environment as they're learning to like stabilize their own load. So when we're quote unquote dysfunctional, the stabilizers aren't working as well as they should be. So what has to take over? When the little muscles aren't doing their job, you get these big movers that take over: the lats, the traps, quads, hamstrings, all those things, because the little muscles that aren't doing their job to stabilize joints are failing. So now you have the big movers take over. So DNS is, again, like we talked about joint centration, trying to help the body pick the optimal muscles during each movement. So I think it's really, really good for that kind of component of trying to retrain motor systems in functional patterns.
Well said. I like that that last thing you said there. That was I haven't heard it that way. How about you, Alex? How would you throw DNS in to your average treatment?
Yeah, I mean, Sean, we obviously think very similarly all here at R2P, and so we've learned from a lot of the same guys, and I have such implemented DNS in a similar way. You'd mentioned we use other things for assessment. DNS does have some of its own assessments, but really, I guess the biggest assessment for me that comes out of DNS is just your 3-month supine breathing, looking to see, can they create that intra-abdominal pressure. And something that we didn't talk on, which is why you guys should go to a DNS seminar, because there's so many facets, but we didn't talk about the difference between respiration, intra-abdominal pressure, primary, secondary respiration. And bracing. There's a big difference between being able to create the pressure with breathing. So when you inhale, increasing that pressure, and then actually being able to increase that pressure without changing your breathing. So independent of that breath. So those are, why I encourage you to go to a seminar. But how, when you assess them in a 3-month supine position, which for those of you who aren't familiar, it just looks like a dead bug, right? You're laying on your back, arms and legs up in the air. and seeing, hey, can they create pressure 360 degrees around their abdomen, even down into their back, and then down as low as possible. I kind of tell patients to breathe towards your feet, right? And there's a lot of different ways that patients respond to those cues. And so that's kind of where the individual part of the assessment, I think, comes in with DNS at least. But as Sean said, the intervention tends to be DNS comes in with the rehab side of things. So you're changing how that joint is being stabilized so that then you can, progress it to doing some kind of movement that resembles more like what they're probably going to do in the gym or in daily life. Like, we're not saying that DNS movements are the end all be all. You should only do closed chain things. It's a great place to get some change because you don't do that very often. But there's a reason that we progressed after that whenever we were 7, 8, 9 months old. Like, we don't need to just stay there for the rest of our lives. But yeah, that's kind of where it comes in for me. It's very much a treatment. A lot of the assessment part is just, can they create that stability for me?
Right. And again, assessment and treatment go along with each other. As you're doing the treatment, you're going to be feeling in there. Like, are you able to maintain that inner abdominal pressure? And are you able to, maintain joint centration? That's the cool thing about DNS. It's also a little bit frustrating as someone who's new to the whole manual therapy and movement world. The fact that, they don't have direct answers with, hey, someone comes in with this hurts their shoulder. Okay, what position should I put them in? Oh, you can kind of do anything. No, like what do I do? They don't. They have a lot of yeah. It's a little frustrating because I came out of my A course. I'm like, okay, like what do I do? Like, I know how to do like a breathing assessment, and that's about all I'm comfortable with. But then I went to the exercise and I kind of learned a little bit more. We did some flows and a lot more of the transition, and like you said, that closed chain, like transitional movements between positions. And it was game changing. And Michael Rentalo is very easy going with a lot of the positions. He's like, yeah, I probably wouldn't even put them in a 3-month supine. I just, whatever they're looking to get better at, we put them in there and just apply the principles. And so at first it's frustrating, but it's really cool that it is something where it's like, okay, these are just, like I said, a definition of how to move, and that can be applied from clinicians to trainers and stuff like that. So it's really cool. As a system, you don't need to learn a bunch of new workouts. I mean, you can, and the things that they do are really cool and effective. I've never, like, it's just body weight stuff, and it just makes you shake so much. Just these little movements. It's like, it's really worthwhile to do it as a course to feel it for yourself and whatnot. But yeah, a lot of people, I think, when they try to put it into practice, it usually just becomes a 3-month supine, get them to breathe kind of thing. MPI does some cool stuff with their integration classes where they blend in some DNS positions. I went to the upper quarter one with Corey Campbell, and he was applying a lot of that oblique sits and stuff like that. That was kind of my intro to, oh, that's how you do a treatment with DNS. It's not just get them to belly breathe and you're done kind of thing. But yeah, what else do we have to talk about? I think we covered quite a few.
Yeah, I think that's, I mean, I feel like that's, for the most part, the beginning of R2P in a nutshell for our club, at least. Like, this is, I think, hopefully this sets a good foundation for those listening who maybe, like you said, don't have a background in these systems, or are new to chiropractic school and you just started going to club. These are the kind of things that you're going to be using every day, and continually expose yourself to them, and they're going to get more familiar. They're going to make more sense. Don't be frustrated if you don't get it the first time. That's with anything that we're learning in school. So keep doing what you're doing. Expose yourself to these things, and it'll stick.
And also, don't feel like you need to deep dive all of them and understand them all really well, because oftentimes some people just learn one, get really good at it, and that's good enough. I mean, obviously the more you can learn, the better. I've heard some people talk about it's better to be a generalist, and and learn a bit of each of them. And then I've heard other people say, like, I just got really good at Mackenzie, and I have a wicked practice and I help a lot of people because I do Mackenzie really well. But it is a little overwhelming to have all these things. And Kai sent me the Shacklock textbook, and I don't even want to open it. I'm like, it's just too much right now.
It's a lot.
So RTP is really great at just giving you here's what you need to know for now, and then go to a course when you can.
Yep.
Let's just summarize what we talked about, because it's been a long podcast. I think we're going to split this up into two, but just so people can kind of bring it back. We started with talking about the neurocentric approach, which is just a top-down way of looking at the nervous system and where pain might be presenting along the nervous system. So we talked a little bit about the brain to start. We're not going to dive deep into that because I don't know if any of us are experts or qualified to speak on the brain and its and that rabbit hole. But then we moved into the spinal cord and the nerve roots, and we talked about Mackenzie being a staple of low back pain and neck pain. They're moving now into derangements of the extremities as well. But we talked about Mackenzie and its uses. Then we talked about moving further out to the peripheral nerves and how neurodynamics can be a useful tool in getting nerves to slide and move properly to get people out of pain when they're presenting with peripheral nerve pain. And then further out, we got into cutaneous nerves and dermal traction method, and essentially doing the same thing, which is just giving the cutaneous nerves more room to move to restore function to those nerves. Then we talked about SFMA, selective functional movement assessment. What it stands for? Nice. Sometimes you forget what some of the acronyms mean. And that was basically just an assessment of function and pain, and basically a flow chart to tell you what a patient might need and how you can help them based on whether they are functional in certain movements and whether those movements are painful. Basically just gives you an arrow of where to start treating the patient. And then we talked about FRC, functional range conditioning, which is a wonderful tool to increase mobility at the joints. And that would tie into your SFMA, whether you need stability versus mobility. So if a patient needed more mobility, then you would probably want to take something out of the FRC playbook, which would include cars and pails and rails. And I'm assuming you listen to the podcast to get to this point, but if not, go back and listen to what pails and rails are and cars. And then we finished on DNS, which is a big topic, but just touching on it, it's a way to create a proper functioning body by way of intra-abdominal pressure and joint centration. And yeah, I think we'll leave it at that. Do you guys have anything to add?
No, I think a lot of like what I had mentioned at the beginning still holds true, that we systematize this a lot for this talk. This isn't the way that any of us are going to treat day by day. We'll pick and choose kind of based on our clinical experience and who we see comes in and our biases towards what we like and what we see works and what we don't like. And that's fine. I think RTP does a really good job of giving you options and then letting you kind of play around in a playground and a sandbox with all that, see what works and see what doesn't. Unfortunately for students like us, we want to know, like, this person comes in, they complain of this, what do I give them? And sometimes there's somewhat of an answer for that, and sometimes there's not. Our goal here is to hopefully give you more answers than questions. But the idea is that this is kind of a playground, like I said, that you just have to mess around in and see what happens. And over time, you'll get to that point of where your mentors are at now, because they were in the same sandbox, if not even a smaller one than you were in. A lot of this stuff didn't exist when a lot of our mentors went through school. So just imagine where we will be in 5 to 10 years.
Totally.
I agree with you guys. As Sean said, don't always live by the system, but this is kind of where, as we're learning in school and student clinic and your preceptorships and whatnot, use these things as kind of your litmus test of how we can figure out how these systems affect someone and then start recognizing patterns of this is what a presentation might look like. This is how I treated it in the past and it responded this way. I wonder if it would happen again. And then if it doesn't, that's when you pick another option, right? So that's where the beautiful thing with R2P, having all of your options at your disposal, it can be daunting to try to decide which one you want to use, but choose one, go with it. If it doesn't work, choose another one. That's kind of the whole premise of it all. So
yeah, definitely while you're in school, play around with them, try to get good at them. And like you said, yeah, just have fun with it. Dr. Snell talks about all these different 3-letter acronyms being these silos, and they have these complete workups, and like, you know, these are all the different diagnoses, and you can pretty much just use our one system to fix everything. And we all know that that's not the case. So don't live in a silo. Don't just take one thing or learn about one thing. Obviously get good at things and dive deep into them, but don't, like you said, live and die by the system. Like there's so much out there, and sometimes something else might have exactly what you need to deal with whatever's happening. Okay, should we sign off? Okay, guys. Well, thanks for listening. Hopefully you guys learned something cool, and comment, rate, subscribe. And if you guys have anything you want us to talk about, let us know, because we're on episode 2. We're slowly running out of things to talk about. I'm just kidding. We got lots.
Cool.
Okay. All right, guys.
Perfect. Let me stop the recording.
Yeah.
Yep, go for it.
Oh, that was